आज का जो हमारा टॉपिक है वो है नी एग्जामिनेशन। नी एग्जामिनेशन में जो सबसे पहले वही चीज़ है जो हम हर एग्जामिनेशन में लेते हैं। वही नेम, एज, सेक्स एंड एनी सोशो इकोनॉमिक स्टेटस, ऑल दैट। आफ्टर दैट, chief complaints, whatever the patient complaining, whether he complaining knee pains or difficulty in walking, whatever. Then histopresenting complaints, histopresenting complaint में whatever is complaining, the complaining knee pain and difficulty in walking. Pain is the what is the onset of the pain, whether it is a gradually progressive or whether it is a fast progressive. Then where the patient first consulted which doctor, and he went. For example, he went to the local practitioner and he took some medications, and he relieved his knee pain, but that is for periodic. And then after that, he consulted here, and for that he given some medications from here, and what are the analysis he took, and how much he is taking the analysis, and whether he able to do his daily activity or not, or whether he is able to walk, how much distance he able to walk, and all this data should be taken. Then in the end, what are the aggravating and relieving factors, all should be taken. And then all the other negative points, like whether his fever, weight loss of appetite, all this should be taken. Then come to your past history, your personal history, family history, general examination, all should be taken. Then comes to your proper knee examination. Proper knee examinations coming first of all, start from the your inspection. First of all, you see the gate you have to, I already discussed gate, and in the other examinations, that if you see your foot progression angle from your midline, and what is the foot progression angle from your midline, it is always should be slightly positive. Okay. Then how is your patella facing, is outward or whatever. Patella almost is neutral position, but it may be slightly positive. But if it is more positive, more outward, then it may be some instability of the patella, whatever the reason for that. Then there is any scar, any dilated vein, any redness of the skin, any other conditions. Okay. So for the skin should be recorded in the inspection. Then in the from the side also you have to, from the from the front also you have to see the whether it is a valgus, any valgus or various deformities is there or not in the front. Inspecting from the front. From the side, if we are inspecting from the side patient, we should be see the whether any wasting of muscles also should be seen from front, and as well that applied for the from the side. Any scar, any dilated vein, any deformity, any wasting of muscles from the side, wasting of the calf, wasting of thigh muscles. And of course, there is from the side. If you inspecting from the lateral side, you should see the any recurve bottom or procer bottom deformity. What is the recurve bottom deformity? Recurve bottom deformity means your knees bending backward, and procer bottom is your knees bending forward. Okay, so the recurve bottom, procer bottom deformity should be seen from the lateral sides, from the side. If you are inspecting from the side, from the inspecting from back, again you would see the wasting of thigh muscles, wasting of calf muscles, and all the scar, dilated veins, and condition of skin redness, all that. Then of course, from the back also, if you any other swelling in the your popliteal fossa, and that may be your the Baker cyst, all that should be seen from the back. So this is the infection. Then coming to the palpation. In the palpation, you have to palpate the knee joint line. So knee joint line, suppose this is a knee, so this is the knee. you have to palpate from side to side knee. Okay, knee joint. Okay, knee joint, you have to palpate knee joint from the side to side. For if it is tender, your knee joint line, then maybe it is your osteoarthritis, or maybe it is your meniscal pathology, or from the patella, from the palpating from the quadricep tendon. If it is your quadricep tendon is a tender, then maybe the quadricep tendinitis, or maybe if it is there is some gap, maybe there is rupture of your quadricep tendon, then comes to your patella. On your patella, that may, if there is some thickening of the skin, or there may be swelling, that may be your prepatellar bursitis. Then coming in the front of the patella, if it is there is thickness or any tenderness, there may be a uh, your um, bursitis, and your patellar tendon bursitis, or maybe your patellar tendonitis. Okay, if there is a tenderness, or maybe it's a gap, then your patellar tendonitis. So all these things will be there. And if you you palpating from side to side your knee joint line, or then co- coming in here, your quadricep tendon coming here, and your from side your iliotibial band also coming. So at the distal part of iliotibial band also to be palpated for the your for the your any sport person, maybe some, there may be some tenderness in the distal part of the iliotibial band. And then coming in the knee, middle side of the knee, middle side of the lower part of the your uh, just upper part of your tibia, there may be some tenderness. Your medially, your upper part of tibia, some tenderness, that may be some your three or four muscle there inserting. There is pace insulin bursitis. There may be a pace insulin bursitis at that site. Okay, so that also to be palpated. So this is the all about palpation. So after palpations, we come to the some uh, test for the. First of all, we come to the if it is your effusion in the some knee effusion is there. If it is your mild, whether it is your mild knee effusion, moderate, or your profound knee effusion. Okay, so mild knee effusion, you have to just do your side to side. You have to sweep the fluid from this side to side. Okay, if it is sweeping, this is, suppose this is the knee, we are sweeping fluid from the side to side, your fluid will be come to other side. Okay, suppose I sweeping from the medial side, so your fluid will come in the lateral side. Okay, like this I'm sweeping in the mild effusion. For your moderate fusion, moderate diffusion, you do patellar tap test. Okay, patellar tap test. So just for sweeping the fluid like this, and then sweeping the fluid like this, and then from your suppose this is your index finger, then you tap the patella, which is your patella coming down and coming up. That is your positive test. Then comes your uh, profound effusion, or massive fusion. In massive fusion, you can say uh, your dimples of the knee will be fully filled, and that is some swelling will be there. And if you push the fluid one side to other side, suppose you is pushing them from middle side to lateral side, then you from other hand you have to palpate that and feel that ballotment. That is the ballotment test we do in the hydrocele, whether in hydrocele as it is, same thing applied. So you have to push the fluid one side, and then you see the ballotment, feel the ballotment on other side. That is the for applied for the your massive fusion or your profound fusion. So this is the your for the your effusion test for effusion. Then comes to your test for the your one of the test for your osteoarthritis, or whatever. Then Suppose this is the knee, just you hold the knee like this, and then just contract your quadriceps. This, suppose this is your quadriceps, you contract that, and then you contract your quadriceps, then see whether there is a pain, see the patient's face, then whether he's feeling some pain or not. Okay, so just holding like this from those two fingers, then ask the patient to put it tight, or make it tight the quadriceps, and then see the patient's face and whether it's feeling some pain or not. That is a your Clark test, or you can say that is your Clark test or Grand test. Okay, so coming to the, your test for your ACL test, ACL tier. First of all, your anterior draw test. Anterior draw test, nothing but is sit on the foot of the patient, and just keep keep the knee like this in your from front, your thumb like this, and your back from your hold like this your knee, and then pushing in front, pushing in front. Okay, pushing in front, anterior drawing. Okay, draw the anterior, the knee. Okay, anterior drawing, pushing in front, and see the there is a whether there is a excessive translation or not, whether there is excessive movement of the knees or not. Like, okay, compared to other sides. That is your anterior draw test. Then in the ACL, one is the anterior draw, next is your Lakeman test. Lakeman test, just opposite, holding one side like this your femur, and other side like this your tibia, and see there is a whether there is excessive translation. Okay, and other modification also there, your keep your knee under your under the patient's knee, keep your knee, bend your knee and keep your knee under the patient's knee, and then repeat this, keep your femur or your thigh, distal part of thigh like this, and your, okay, your tibia, proximal tibia, and then see whether there is excessive translation or not. This is the modification of the your Lakeman test. Then comes your other test. This is Lely's sign, or your liver sign. That is nothing but the suppose this is your thigh, and keep your thigh like this, and your this is your foot. Okay, keep your hand under your thigh, uh, under your, sorry, calf muscle, then you push this thigh from the other hand. Then normal person, your foot will be lift, but if there is a ACL tear, or the patient will not able to lift this your foot. That is your liver sign or Lely's test. The other thing is your pivot shift test. Pivot shift test is just grab your grab the patient's foot, or in your hand, and just from the flexion, you give the valgus force on the knee, from flexion to the, then key, make the knee extension, give valgus force. So that is your, that is your what to say, that is your uh, pivot shift test. Okay, then comes to your posterior cruciate ligament. Posterior cruciate ligament, one is the your shake sign. So your shake sign, what is your shake sign? Your both knees, your in front, your both knees at the same level, if it is some shake or not. Okay, sorry for that, I am not able to demonstrate because I am not having any demonstrator person with me. So your suppose this is your knee, and your both knees, and then you have to see some sag or not. Okay, whether some sag, your anteriorly some sag or not, or your tuberosity pushed back or not, some, okay, some your tibial tuberosity is pushed or back or not. So this sag sign is positive, then is your positive for your ACL tear. Other than sag sign, Other test is your posterior draw test, the same like your anterior draw test. In that, in anterior draw you draw anteriorly, then posterior draw you draw the knee posteriorly. Okay? You sit on the foot of the patient, take permission from the patient, then sit on the foot of the patient, then you have to just push the knee posteriorly, then see there is excessive translation or excessive movement of the knee or not. So that is your posterior draw test for the PCL tear. Then after that, one is your quadricep active test for the PCL tear. Quadricep active test nothing but you just bend the knee in flexion around roughly around 90 degree. Then ask the patient, you have to hold the patient's knee like this. Then ask the patient to push your hand. Then he actively push your hand and then see the any whether his sag is disappear or not. Okay, that is seen, should be seen. That is your uh, quadricep active test for the PCL tear. After the PCL tear, some test for the your posterolateral quadrant test. Okay, your posterolateral corner test, some posterolateral corner for ACL combined test, that also is there. That may be your one of the test your um, uh, what to say, that is your recurve bottom test. Okay, external rotation recurve bottom test, that is your your for your ACL as well as your posterolateral corner, your external rotation recurve bottom test. So what is the external rotation recurve bottom test? Just hold your both foots of your patient and then see that there is hyperextension or not. So that is your external hyperextension and external rotation of foot or not. Okay, that is your external rotation recurve bottom test. Then comes to your dial test. Dial test for the PCL plus your posterolateral corner. The dial test is nothing but you do the you ask the patient to lie in the prone position, then ask the patient bend his knee, and then roughly you hold the knee, hold the foot of the patient external rotation and at the 30 degree and as well as in 90 degree. If it is at the positive at the 30 degree and negative at 90 degree, that is for the posterolateral corner is gone. If it is positive both, then 30 degree and 90 degree, then your PCL as well as your posterolateral corner both are gone. Okay, it means your hyperextension, your sorry, external rotation is more. Okay, in dial test, if there is a more external rotation at 30 degree and 90 degree, that means your both your PCL as well as your posterolateral corner also gone. Okay, posterior corner also gone. So these are the your test. Then comes your meniscus. For meniscus, one of the main test, that is your McMurray's test. McMurray's test is nothing but uh, for the medial meniscus, just give your from lateral to medial force, then hold this like, give lateral to medial force and hold the knee from the just you have to internal external rotate for the medial meniscus. You have to external rotate the foot, okay, of the leg of the patient. You have to external rotate and give valgus force and then see the patient's face, and from the flexion to the extension of the knee. Okay, from the flexion extension of the knee. Okay, same for the lateral meniscus. You have give force from the medially and then internal rotate the foot of the patient, then from the flexion, from flexion to the extension of the knee. Okay, from the flexions, first of all you have to see the your posterior horn, then in the middle your middle horn, and in the anterior when you are extending the knee, anterior horn of the patient in the McMurray's test. McMurray's, after McMurray's, you're coming to the, your Applis grinder. Applis grinder nothing but you ask the patient to prone, then just you and then ask the patient prone and sit, lie in the prone, and flex the knee in 90 degree, then just hold the foot and just grind that, just rotate. That is Apis grind test. Okay, you will see the patient whether he is feeling some pain or not. So all this test is one of the Thessalis test also there. Just stand one foot and flex other foot. Sorry, stand on the one knee and flex other knee. Then just rotate on the one knee. Okay, other knee you have to flex in the air, and rotate other knee. Okay, that is your Thessalis test. So all these tests for your meniscus tear. So these are the main examination of your knee. After the examination of knee, we are coming to the some points about the your total knee replacement. So in total knee replacement, first of all, you have to give. Suppose this is the knee, you have to give center incision. Okay, incision, then retract the skin from your retractors, and raise the flaps as well as the dissect fascia properly, and then your quadricep tendon and your quadricep tendon and your patella tendon will be get exposed. So you have to then also patella will be exposed. So from the side of the quadricep tendon and side of the patella, you have to give incision from the side of the quadricep tendon, side of the patella, and side of your patella tendon. Then give incision, then evert the patella. After everting patella, patella should be everted gently, because there may be tear of even you are not everting gently, there may be tear of your patellar tendon. Okay, so after everting of patella, then you remove some extra pad of fat. Okay, and extra osteophytes, all that should be removed, that coming into your way. Then for preparation of the your tibia, whether you use using or your intramedullary jig or extramedullary jig, you have to decide that. Then if you're using extramedullary jig, so suppose you're using extramedullary jig, then you have to decide that what degree external rotation and what size of the patella tibia you have to take out. Okay, so you have to adjust your jigs like that. Suppose you have taken 8 mm, then you have adjust on the 8 mm. Whatever you have to taking, adjust the your jig like that, and you whatever the your rotation you taking, 5 degree, 10 degrees, 9 degree, whatever the rotation, you have to put that your jig on that basis. Then you have to cut using your that you have to cut your patella, sorry, your tibia, proximal tibia. Then whatever you cut, make that remove from the help of your what to say, your broad osteotome, or your nibbler, all that. Then so after this, you have to prepare your femur as well. Femur, you may use femur mostly using your intramedullary jig. So you have to drill first your femur, then put your jig inside after drilling. Then after putting the jig inside, you again you have to see the how much your femur you have to take, whether you taking 9 mm, 10 mm, whatever, or whether which angle you have to put that. And okay, all these should be keep in the mind all. Okay, and after taking your uh, femur, then you have to cut the femur condyle also. For that also you have to put the jig, and femur condyle also to be take out. Then your after that you have to cut the box cut in the femur also. So all that you have to do in the. Okay, for that you have to properly use your jig. For that you have the your version of the jig, or all that part, and the version, all that you have to look all that things. Okay, uh, then mm, anti-version or retroversion. Some jig is referring anti-version. Anti-version means your sizing of your implant that is coming in from the front. That is anti-version. Your sizing coming from the behind. That is your retroversion. Then what size of you taking, that also telling your special instrument. Okay, like you are taking 16 plants, 65, 70, 75, whatever. So that also tell it, you're telling only your some special instrument only. So that then you have to all after all that you have to do the proper washing of the your wound, and then keep the trial whether it is fitting or not your uh, whatever you're thinking, whatever the size you're thinking, whether it's fitting or not. You do extension flexion of the flesh of the knee, then you look the whether it is fitting or not. Whatever the size is fitting, you fit that in the end using the cement, and then you proper washing of the your wound, and in the end you have to uh, close the wound properly. And just all that is a brief about the total knee replacement. That's briefly about the examination of knee and the total knee replacement. So that's all for today. Okay.